brilliant people working at the front line. We've got some brilliant leadership capability throughout the NHS. We need to set them free to do the job as well as holding them to account. And finally, the most important revolution of all, as far as I'm concerned, is the revolution needed in patient power. When Nye Bevan established the NHS in 1948, he said he wanted it to hold a megaphone up to the mouth of every patient. But the NHS that we see today is a far cry from that vision. Patient voices are too often unheard, their complaints dismissed or discouraged, and the NHS needs to move with the times. Patients need to have far more ease, convenience, choice and control over their healthcare, and that's at the centre of the plan.
Fantastic. So that goes very nicely into the first question that I want to ask. You've talked about the 3 shifts at the core of the plan and the long-standing ambitions, but Wes, we have seen these in multiple NHS strategies, for at least the last 30 years. So the question I'd like to ask you is, why do you feel this plan will succeed when so many others have failed?
Yeah, it's a very good question. You're right, the 3 shifts were not in themselves radical new ideas, but delivering them really would be. Why now and not before? I think there are a few things in our favour. The first is the sense of jeopardy that the public feel about the future of the NHS is felt right throughout the service. We've prosecuted an argument in opposition and now in government that it's change or bust, reform or die, and I think that there is overwhelming consensus in that direction. People in the NHS want to see it change, they know it needs to change, and they are up for it. Secondly, how we do the change is as important as what the change is, because if you think, thinking about some of the things contained in the plan, whether they're new models of service delivery, new commissioning arrangements, new innovation in terms of medical science and technology, we will only succeed in delivering this plan if we're doing change with people rather than to them. And that's why, in terms of how we've approached some of the challenges as a government so far and how we will deliver this plan, we will make sure that the implementation is designed with as well as delivered with people throughout the system. And already, Jim may want to say more about this, we've had people banging down the door since the plan was launched saying, we're really interested in this new model of neighbourhood health, we want to go first. We're really interested in the reinvigorated foundation trust model. How can we have a piece of that action? These integrated health organisations, how can I be part of it? And that's exciting for me because we can
Wes, do you want
get
me
those
to
people
bring Jim in now so that he can just finish that off?
Yeah, so just
Jim,
to add to that, we had a chief execs gathering on Thursday where we've created some groups to develop the next parts of the plan on neighbourhood health, integrated health organisations, the medium-term planning and financial rules. So a handful of bits of work, the NHS app, etc. Really strong engagement. So the last count, this is still moving, there are about 120 volunteers for chief execs and their organisations to participate and want to get out in front. I've actually just left a call with a colleague ahead of a session later on where Secretary of State's pointed out there's this real tension of real ambition and desire to get out and start delivering this stuff at pace, a will to work in a new way, but also wanting more detail. And we just got to get that balance right and hold our nerve on, we'll develop the detail with colleagues in the service because that'll work better and it'll give us a better chance of success. So that's really what the next few weeks are about.
So what do you feel has been, from the previous attempts we've tried at reforming, what do you feel we've learned from those previous attempts that we can bring in to this particular reform?
So I think the worst thing we could do is to take the plan and the end state that we're aiming towards and try and impose it all in one go now. I think the lesson of the Lansley reforms is that a big top-down reorganisation imposed on the system doesn't work. And when you follow through the logic of some of what Andrew Lansley was saying, I could see the method in his madness, but the execution was really poorly done, and some of the ideas at the outset were ill-conceived. And I know we've taken a bit of flack for the fact that we did a big engagement exercise to build the plan, and we will take some flack for the fact we're working with people on designing implementation, but that is a far, far better approach than the alternatives that we've seen. And I think the other thing to that point as well, with some of the models we're going to roll out, particularly think about primary care, like the principle is you set people free to lead the path to the future, to show us how the new model will work, to be the early adopters and the pioneers, and in doing so inspire other people to follow. And doing that in a way that doesn't go in like a bull in a china shop and say to a primary care network, for example, although you're working really well and you're driving innovation and you can demonstrate year-on-year improvements, we, the government in Whitehall, have decided that we don't like your model, we're going for a different one, and we're just going to go in, like a bull in a china shop through your thing that's working. So we're not interested in going in and bulldozing through things that are working in pursuit of the thing that we think will be the future. Far better to let people themselves opt to be the pioneers, to show how it will work in practice, and then inspire other people to follow.
Really good place to stop there. So my next question is relating to dentistry. And last week we had Minister Kinnock, who told the committee funding for dentistry was likely to be in the region of the current financial envelope. Given the ambitions and the plans you have to reform NHS dentistry, why have you not committed to increasing the dentistry funding to pre-pandemic levels? Will you be reconsidering your decision?
Well, so a few things in response to that. The first thing we could do is make sure that we are making the most of the money that's already going in. And in opposition, we complained a lot about dentistry underspends. And one of the ways in which we'll be looking to address that, obviously some of the things we're already doing, the 700,000 urgent appointments that are being rolled out, but we know that fundamental contract reform is needed. There is a tension, there is a constant tension for me between the level of ambition we have as a government, the level of demand put on us by the Parliament and the public, and the choices and trade-offs that we face when trying to deal with an NHS that has such a breadth and depth of challenges. So,
Wes, let me stop you there, because you could talk for another 5 minutes and I haven't got 5 minutes. Will you be considering that decision?
I said I was scared of you during this meeting.
Shut up, Wes. Will you be reconsidering it?
Look, it is something we are constantly put under pressure on from Parliament and the public. We will do as much as we can, as fast as we can on NHS dentistry.
Absolutely awesome. And my final question is around palliative care. So, palliative care does not feature significantly in the 10-year plan. What I've noticed is it's been mentioned, I think, about 4 times with all the experts that have trolled through it. And also in the index, you mentioned something about palliative care, but it wasn't actually, nothing was said on palliative care. With all the issues we've now got to address inequalities, we're looking at palliative care through the 10-year plan, also through the context of the terminally ill. How are you planning to address palliative care going forward? Because that is becoming, I'm going to use the word from last week, a burning platform.
Yeah, so palliative care does feature, particularly in the context of neighbourhood health services, and I feel very strongly, and having seen palliative care in a range of settings and frankly a range of quality of provision, the principle we want to see in palliative care is the same as the rest of the NHS, which is giving people real choice over the care they receive, when they receive it and where they receive it. And for some people that will be in hospices, for some people that will be the comfort of their own home. Wherever possible, we'd prefer it to be the latter, but that won't be right for everyone. We've obviously taken some steps already in our first year with £100 million for hospices through capital investment. which has been used to good effect to either expand or modernise estates, or often buy the kit that's necessary to provide good hospice at home care. And the £26 million children hospice grant, I know, has made a real difference as well.
Whereas if we talk to the sector, what they're saying is they've used over 70 million of that 100 million to do the national insurance payments. So it's only left them with, I think, about 24 million. This is what they're telling me. And what they've said is this is going to become a burning platform in months to come, because that money is running out, and some of the organisations are actually saying now that they will be closed in the next 6 months to a year if they don't get the support they need.
So I'd say, I've never been comfortable with the extent to which hospices are reliant on the generosity of the public through donations to fund something that I think in today's day and age is an integral part of the health and social care system. What I can't do, with the scale of the challenge that we currently stare into and the pressures on the public finances, commit to moving us as far down that route to state funding as I would like. So in the meantime, I think certainly we will continue to do everything we can through state investment. I indicated at a reception recently for Havens House Children's Hospices, which serves my constituency, and we had Hospice UK and Together for Short Lives and other amazing charities there. I think it's worth us looking at what we can do with the sector to see if we can leverage in more support through things like match funding and other schemes to try and get more investment into the sector. So we're open to those sorts of conversations.
And I know they appreciate that. So my last point would be, when will you start considering working with the sector to look at a new strategy, read the way forward? Because that was talked about last year, and the sector really do want to work with the government, like many others, to just get to that point where they feel as if they're being heard and being inclusive. So how long will we be looking at the government really starting to work with this sector? And it just needs to be a few words.
Yeah, and we do engage with the sector. I will certainly pick up your line of inquiry with them. But the second thing, I know there's been an initiative for a commission on end-of-life care, which has been established. It's independent of government. We'll be following their work carefully and looking at what they recommend as well.
Thank you, Wes. Can I hand you straight over to my second committee member, and it's Joe Robinson.
Afternoon, Secretary of State. I'm going to stick with some of the bigger themes that we dealt with at the beginning. In fact, you've already touched on some of them. And I'm going to quote, "Investment has to be accompanied by reform. The NHS has to be redesigned around the needs of the patient. Local hospitals cannot be run from Whitehall. There will be a new relationship between the department and the NHS, etc." Presumably that's an underpinning principle that leads to things like a decision to abolish NHS England.
Yeah, that's absolutely right. And what we're trying to do is a few things. One is to shrink the size of the centre, make its focus more strategic and holding the system to account on outcomes, and devolving as much power, resource and responsibility closer to the front line and at the front line as we possibly can. We also want to make sure that our financial flows and incentives are aligned with our public policy objectives. So, because if there's one thing I've learned about this system in the last few years that I've been in this portfolio, is that money talks. And if you get your incentives aligned or indeed misaligned, you either get the desired outcomes or the completely unintended outcomes. And that's why working with the system on the design of those is going to be really important. We also want to make sure through the technology and innovation side that we've got a big focus on productivity, because it's one of the big challenges, not just for the NHS, but given the size of the NHS, it's a challenge for the British economy.
Could I just try another one?
The NHS is more as productive as possible.
Yeah. Could I try another one, which I hope you'll agree is a theme, a different theme, but nevertheless a theme. So, quote, "The NHS has been too slow to change in its ways of working to meet modern patient expectations for fast, convenient, 24-hour personalised care. Changes in primary care will help ease the pressure on hospitals so that they can concentrate on providing specialist care. I mean, that, presumably in a nutshell, is the shift from hospital to community.
Completely agree.
Yeah. So my concern is that absolutely none of this is new. Well-meaning, well-intentioned, but none of it new, because the two quotes I've just given you are actually lifted directly from Alan Milburn's NHS plan in the year 2000.
And that plan delivered the shortest waiting times and the highest patient satisfaction in history, so it sounds like we're on the right track. But there's lots of stuff in the plan.
Is this a back to the future? Are you Doc Brown taking us back to the year 2000 to sort out the NHS?
No, I've not gone that grey in this job yet. But I think the themes are, as I think we said in response to the chair's questioning, like the shifts themselves are not new ideas. Delivering them in practice in this NHS really would be. And there are lots of things contained within the plan that are new models, new ways of working, a new approach to innovation, adoption and rollout. So there's plenty of things in there on the prevention side that are novel and innovative, as well as things that are well evidenced and need to be rolled out more consistently.
Perhaps you can help. What's the difference between community diagnostic centres, multidisciplinary GP surgeries, DARSI centres, and now, your word for it, neighbourhood hubs? I mean, these are things that have run from the year 2000, 2008, 2012, and now your plan. They sound like the same thing, just with different names. Your name is neighbourhood hubs. Perhaps you can start by telling us how that's different from community diagnostic centres or DARSI centres from 2008.
Well, DARSI centres, or polyclinics as they were known, were effectively strangled at birth. There are still a few around. It was a source of huge controversy at the time for something that I think, as an approach, I think people agree doing neighbourhood health and population health at scale is a good thing to do, and that was certainly borne out through the consultation. Community diagnostic centres are by definition diagnostic centres, and what neighbourhood health centres will do is bring under one roof a whole range of different services to give patients a one-stop shop with the principle that anything that can be done outside of a hospital setting in communities, in neighbourhoods, should be. Hospitals should be for the most serious cases, complicated procedures, operations. What we want to see happening in neighbourhoods is the opportunity to go in and get much faster access to consultations and diagnostics, to be able to have things like your blood tests, scans, all under one roof. Minor injuries, urgent treatment centres, all of that can be done in primary care. And the reason we know that to be true is because in pockets of exceptional practice in this country, it's already happening. And one of the core themes of the plan is to take the best of the NHS to the rest of the NHS.
When Tony Blair and Alan Milburn were doing this in the 2000s, like you said, it delivered the sort of healthcare that you'd like to see. They were spending 6.8% increase year on year on health. You and Rachel Reeves have got a plan to spend 2.7% according to the last budget. So how are you going to deliver spending historically low figures? In fact, 2.7% is lower than the 3.5% of the last Conservative government. I'm just interested as how you're going to pay for this.
Well, it's why investment needs to be matched with reform. And the economic circumstances were very different for the last Labour government. This is a government that has to live within its means. But as I've argued for some time, the NHS has become more bloated. There is waste in the NHS. And the last government is a good kind of case in point as to why you can't just throw money at the problem. Because if it was a case of just throwing money at the problem solves the problem, the last Conservative government should have had a decent run at it. They poured quite a lot more money into our hospitals, significantly expanded staff in our hospitals, and you would think with the pressure hospitals are under, sensible thing, right? Except that all of the congestion caused in hospitals finds its route outside. So it's either people can't get the right primary care, or they can't get access to primary care soon enough, or care in the community, so they end up going through the front door of the hospital, either in an emergency department or onto an elective list in a far worse condition they would otherwise have been in had someone got to them sooner. Or they're then stuck in a hospital bed and can't get out because there either isn't the social care or community care bed capacity available. And so what we're doing is a system-wide approach that recognises that if you want to improve the flow of patients through hospital and everything from your A&E waits, your elective times, delayed discharge performance. You've got to deal with primary care to deal with the problems at the front door, and you need to deal with social and community care to deal with the problems at the exit door, put crudely.
If we take this plan, which is a set of good aims, as we've agreed, there's nothing hugely revolutionary or radical there in terms of the overarching themes. My view is the one opportunity you've got to succeed where perhaps other governments have only partially succeeded is the delivery, is how do we do the change? But there's so little in here about how you're going to deliver. So perhaps you can tell us how to get to the end point, which is in this document. And if you can tell us about that, where can we see it written down? I'd like assurances it's not still only in your head.
No, we'll keep coming back to you as a committee as well. But look, this comes back to the very first line of questioning, which is there is a way of doing this, which is imposition of change, or there's a way of doing this which is about taking people with you. So on everything from the new governance arrangements for the reinvigorated foundation trust model, to how integrated health organisations will work, to how we'll deliver neighbourhood health, we'll be doing that with system leaders. We'll be setting some people free to go faster than everyone else and to show us what the future looks like. And then others will follow.
And the Chancellor's on board with the money?
She is, yep.
Good to hear.
And the budget and the spending review. And I know that the public finances are under pressure. That's why I was sensible enough to bring the Chancellor to the launch of the plan.
Thank you. Thank you, Secretary of State.
Oh, thank you for that, Joe. Can we go swiftly over to Becky, please?
Thank you, Chair, and thank you for coming along today, Secretary of State, Sally and Sir Jim. If we can move on to population and public health, please. So if we continue your theme, Secretary of State, about money talking, could you please outline to the committee how the finances are going to align with your sickness to prevention shift? And specifically, in 10 years' time, what percentage change should we expect to see in these areas?
Oh, I'm definitely not going to write the budget for 10 years down the line.
But would we expect to see a change, Secretary of State, in terms of the shift from sickness to prevention and the money following it?
Yeah, and look, over time, what we want to do is see far less spent on the price of failure. And obesity costs the NHS 7.3 billion a year, alcohol 4.9 billion a year, tobacco still, despite all the progress we've made, 1.9 billion. Economic inactivity due to sickness. In the NHS, 2 billion cost to the economy. So you can see sort of right across the board we're paying a very high price for failure. What we've set out in the plan are a number of approaches, some of which you would consider a sort of conventional public health, and obviously we've got the tobacco and vapes bill going through Parliament, which in terms of the impact and benefit of the policy would provide the NHS with £6.6 billion worth of savings, and we're going to go further by clamping down on vaping of young people. But then there are kind of more radical approaches. So what we're proposing is to do with supermarkets, for example, to improve the nutritional value of the average shop. I don't think has been tried anywhere else in the world. The genesis of the policy was an idea from Nesta, who we've worked with to develop that policy. We've got a number of the big supermarkets on board. And taking that approach will lead to a very different sort of approach, not just from the state, but from the food and drink industry as well.
Okay, Secretary of State, so perhaps we'll go straight to that then. So a voluntary arrangement with large food companies has been tried before under the previous administration. Prime Minister Cameron tried this and yielded very poor results. In fact, the only evidence-based increase really was around the legislative food tax. So how is this voluntary agreement going to be different to previous voluntary agreements?
Well, the reporting and the target would be mandatory. We want to work with the industry to get it right. So it's not in any of our interests for it to fail. But the data on the food and the drink that we buy from supermarkets is already held by them. It's some of the best public health data in the world. They had already been calling on us to publish the data. And so that's the bit we should look to do with them most quickly. But then I think we should work with the industry to set a target for improving the nutritional value of the average trolley or basket.
Okay, and I agree, the public health data are good, but I'm sure that you're aware that in terms of socioeconomically deprived areas, there is a substantive number of our population who do not access their food and their nutrition through supermarkets, and therefore how is this particular initiative going to address those inequalities, and if it's not, how are you looking at the nutrition of people who are in what we call food deserts, where they're accessing their foods through smaller shops, etc.?
So 85% of our shops come from supermarkets. I take the point you're making about the exceptions and some of the areas of the highest levels of deprivation. I don't think we should let perfect be the enemy of the good. I agree,
Secretary of State, but in terms of proportionate universalism, if you were going to put your investment into a place that would make a substantive difference, would you not agree that you would put it into the most deprived areas to see that improvement, which I think actually is your aim in your 10-year strategy?
Yeah, and that's why in a speech in Blackpool recently, I announced our determination to change our funding formula for investment in public health to target those areas of highest level of need and deprivation. We'll be taking a similar approach to reform of the Cahill formula for general practice. I think it's a disgrace, frankly, that if you are living in the poorest community in the country, there'll be about 300 more patients per head than the most affluent, so it's the inverse care law, like writ large. But the supermarkets thing is significant because by setting the target in the way that we will and actually giving industry the freedom to innovate, I think we will see things like loss leaders and price promotions on the healthiest products. I think we will see supermarkets thinking more creatively and ethically about their marketing practices, the layouts of their shops, and the wonderful thing about this approach we're proposing, if we get it right, is actually it will lead to less nanny statism, ironically, because rather than having the Secretary of State trying to dictate price points, promotions, location of the chocolate in the supermarkets and anything else that I might be tempted to meddle in to make the nation healthier, if supermarkets are driving towards the goal of more nutritious sales, they will know their customers best. They will know what works well in terms of nudging people in the right direction, and that's why I think this sort of partnership approach, I think, is I think the third way between kind of nanny statism on one hand and being very directional, or kind of just taking a step back and being completely laissez-faire about it.
Okay, so I look forward to seeing how the choice architecture improves our lives. The data so far don't back it up, but I very much hope that you're correct. Can I go to something that perhaps is more directional, which is alcohol, which you mentioned the cost of alcohol to the National Health Service and to people's lives. So could I ask why in this 10-year strategy we are not making a commitment to set a minimum unit price when the available evidence shows that this is an effective way of reducing harmful alcohol intake?
Minimum unit pricing, I know that there is a loud campaign in favour of minimum unit pricing. That's not something the government has chosen to proceed with at this time. I'm sure there'll be a healthy debate on that in Parliament. What we are proposing to do is give the consumer more health information. It is a bit daft that you can, get more nutritional information about a can of fizzy drink or a packet of crisps on the shelf in the supermarket, but when it comes to the number of calories in a pint versus a gin and tonic or a gin and slim versus a glass of wine, we don't make that information available to consumers, and I think we really ought to. We do need to go further on tackling what I would describe as problem drinking. 4% of people drink as much as 30% of the alcohol consumed each year, and they do that at serious consequences to their own health and sometimes to the detriment of their own lives. And that is the issue I think we need to, with the whole sector, have a more focused approach to tackling.
Okay, so I look forward to that robust debate on minimum unit pricing. Perhaps moving on to something else that is also in our legislative agenda, which is the junk food advertising ban before the watershed. Could you explain why that's being delayed, please?
Well, it's still it's coming in from the new year. There were perfectly reasonable, legitimate concerns about going as fast as we were proposing to.
Sorry, Secretary of State, what were they?
The readiness of the industry to comply and the way in which the regulations would be subject to potentially misinterpretation. So I think it's fair to say the industry, they know it's coming. It's definitely happening. There's no wriggling out of it. And actually what you'll see in the run-up to Christmas is widespread compliance. But there was I think a reasonable debate about brand advertising versus product advertising, and we wanted to work with people through those issues so that the law actually works in practice rather than catches people up with laws of unintended consequences. So that's the only reason for that delay, but you should still see widespread compliance.
Okay, and just to explain, if you can, around the branding issue, so is the conversation that you can't show the product per se, so the food product, but the argument from the industry is that they should be allowed to advertise their brand? Is that the argument that's going on?
In a nutshell.
Okay, and do you have a sense about where that's going to land yet or not?
We'll keep you updated.
Okay, thank you. And my final question is around the health mission. So obviously the National Health Service, it's great that it's going to be a National Health Service again, but I know that you're all too aware that health in and of itself is, it should be a mission across all the directorates and into local authorities. So I just wanted to ask, it's gone quite quiet, is the health mission still alive? And if so, how is it shaping the broader health prevention agenda with this 10-year strategy? And if it's, died a death, who and how is now are now shaping this very important issue across the relevant directorates? No,
it's still very much alive, and one of the things that is working really well in the health mission is the way in which we're firstly galvanising other government departments behind the focus on public health and prevention. So on this policy I mentioned on supermarkets, for example, would not have been possible without the joint working between my department and DEFRA and the support of Steve Reed, the Environment Secretary. Similarly, the work that Lisa Nandy is doing to try and reorientate our cultural and sporting offer to underserved working class communities with high levels of deprivation need across the country, very much aligned with the health mission. Bridget Phillipson's work on not just expanding free school meals and breakfast clubs, but making sure they are nutritional. The work that we're doing in partnership with DFE and DCMS on school sports and making sure we've got qualified PE teachers, upskilling education on PE and games in our schools, all really important stuff. And there's a whole load of stuff just like that that's coming together under the health mission. But we're also looking... Is housing and air quality, are they there and live? Yeah, look, one of the things that is exciting about the Deputy Prime Minister's commitment to build 1.5 million new homes is that one of the biggest challenges we see are the number of children living in temporary bed and breakfast accommodation, not able to have decent space to live and learn and play, often in accommodation that doesn't even have basic cooking facilities, and so the takeaway is the only option. All of those things, all of the social determinants of ill health, that is what we as a government are committed to tackling. And moreover, we can't do this as government alone. We need to work with business and civil society, the private sector and the voluntary sector, to bring all of this to life, and that's exactly what we're doing. The supermarkets policy is a good example of working with the private sector. We've got an exciting collaboration which is coming out tomorrow to get more young people kind of physically active and engaged to tackle the issue of obesity amongst primary age children. So you can expect much more of this sort of stuff coming out of government in partnership with business and civil society. Great, and just to say that obviously the public health workforce is a key part of this, and I appreciate that they don't sit all in the national health system, they sit in local authorities and in different places. I note that there's not a specific plan around the public health workforce per se yet, so presumably will that be looked at in partnership with local authorities? Yeah, I very much see, especially as a former Cabinet Minister for Health and Wellbeing and Local Government, I very much see DPHs and the public health team as part of our team. And we're improving all the time the relationship between my department and Directors of Adult Social Services and Directors of Public Health. as well as elected members as well. And one of the things what I'm committed to doing with the LGA is, as part of the delivery of the 10-year plan, making sure that we've got much stronger institutional relationships, not just between Whitehall and communities across the country, but also across communities between the NHS, local government, and social care and the voluntary sector as well.
Thank you.
Thank you, Becky. Straight over to you, Alex.
Thank you, Chair. Thank you, Secretary of State, for your answer so far. Just to carry on the theme from Becky's questioning. I know what you say about the supermarkets holding a lot of data, and it strikes me that another group of organisations that will have an awful lot of data about our eating habits is the delivery companies, Deliveroo's and Just Eats of this world. Is there any work the department's doing that is thinking about maybe bringing them into a similar type of arrangement that we have, that you're suggesting with the supermarkets, so that we can tackle the takeaways and the slightly less healthy food habits that some of us might have?
Yeah, I think the out-of-home sector has got a role to play, and I think you're right, and this is potentially the way in which we can help to improve the picture in the SME part of the sector. Like, government, rightly in my view, takes a much more cautious approach when it comes to regulation of your small businesses. And we recognise that asking people to do things like calorie labelling on menus or other changes to how their business runs comes at a cost, and for some businesses complexity that they can't afford. And we don't, especially the pressures on our high street, especially the pressures in the economy, we don't want to make life harder for small businesses. And look, I enjoy takeaway as much as anyone else, so on all of these things I'm not coming at this from the point of view of being the fun police. As one or two drivers to my house would attest when they're dropping off my takeaway. But those sorts of platforms like Uber Eats, like Deliveroo, they do actually have a lot of really valuable information about their customers' eating habits and about the food that's being sold through their partners in the sector as well. So I think it's fair to say they've got a different starting point to the supermarkets, but we are absolutely committed to working with the out-of-home sector.
Great, thank you. I'm going to move swiftly on, given timing. You mentioned in your response to the Chair some of the criticism about going through a period of consultation. I guess what did you learn from the consultation on the 10-year plan that you didn't know before you started?
Oh, loads of stuff. I mean, even on prevention, we sort of went in asking questions very much about the NHS. And I know that the public do care about health and well-being more generally, but we didn't expect the sort of visceral reaction we got from people who were saying, if you're not doing public health and if you're not doing prevention, then this plan isn't going to work. So there was a real awareness on that and pressure from the public, which I think is really important, especially in a political context where we're often kind of told that, doing stuff on public health kind of gets kind of resistance from the public. Actually, a lot of what we heard was, help us make healthier choices, help us make easier choices, help make activity more affordable. I think the other thing that we learned, if you take the technology side of things, both from the public and staff side of things, people instinctively get it, particularly in the amongst NHS staff. Lots of them are scientists. So they're really excited and aware of and enthusiastic about AI, machine learning, data, genomics, and all of the other stuff that's going to completely change the paradigm of health in this country and around the world this century. But what they were often saying to me directly, as well as through the engagement exercise we did, is it's all very exciting. I can't even get my machine to turn on reliably in the morning. I'm using 7 different passwords to log on to deal with a single patient. And so kind of what we learned there is that if you get the basics right, you'll get a lot of trust for the stuff that follows. And I'm amazed that this hasn't made more front pages or grabbed the headlines, but our commitment in 2026, 2027 to give all staff a single login to deal with the 7 passwords issue, I mean, I can't believe that has not been greeted with a level of fanfare as some of the other ideas in the 10-year plan. But actually, in all seriousness, it's really important because it will prove to staff, you know, to the point that Joe was asking about and the Chair was asking about. You've got, I think, a lot of people out there that are willing us to succeed, but are still sceptical about whether some of these things are going to happen. Sure. So the more we can prove more quickly, I think the more momentum we'll build behind the plan.
Great. And moving on to workforce, obviously workforce can be very key in delivering this 10-year plan, and it would be remiss of me not to take this opportunity to ask you about the strike, threatened strike action from the BMA. Could you update the committee on the progress you've made on securing a meeting with the BMA's Resident Doctors Committee?
Yeah, so I'm pleased to report that the BMA have taken up my offer of meeting this week. So we will be meeting to see if we can find a way to avert strike action. I have to be clear with the committee, as I was with the House last week, that there is no more room for manoeuvre on pay, but there are lots of other things that we can do and should do that would lead to material improvements to resident doctors' lives now and into the future, including on progression. But these things are always choices and trade-offs. Lots of things that resident doctors are asking for in terms of things like doctor unemployment or progression into specialty posts, both of which I agree with them on. They do cost money. Many of the other things that we want to do in the NHS cost money. And that's why going on strike, having received a 28.9% pay increase, is not only unreasonable and unnecessary, given the progress that we've been making on pay and other issues, it's also self-defeating because it will come at a cost of the things that we want to invest in to improve the NHS. And at a time when the NHS is moving in the right direction, when waiting lists are falling, GP numbers are going up, and people are feeling a sense of cautious optimism about the NHS's future, I think it would be a catastrophic mistake for the BMA to throw all of that progress into reverse by walking out on strike. The public don't support it. Even a majority of resident doctors didn't vote for it. So I hope that when we meet, we can see a way through this that avoids the misery that will be inflicted, not just on patients, most importantly, but also on other NHS staff and the future of the NHS.
Thank you, Secretary of State. And in terms of, obviously, they've announced an initial 5-day strike. If that was to go ahead, what assessments has the Department done on what the impact that might have on elective waiting lists?
Well, actually, I should probably bring in Jim as well on operational planning, but I'd just say a couple of things. We can mitigate against the impact of strikes, and we will, but what we can't do is promise that there will be no consequence and no delay, no further suffering, because there are lots of people whose procedures are scheduled over that weekend period and in the period subsequently where the NHS has to recover from the industrial action, who will see their operations and appointments delayed. I have a relative in that position. My family are currently dreading what I fear is an inevitable phone call saying that there is going to be a delay to this procedure, and I just think this is an unconscionable thing to do to the public, not least given the 28.9% pay rise. The other thing that I have found actually shockingly irresponsible about the BMA's position is their leaders seem to be telling their members not to inform their trusts or their employers if they're going out on strike. Now, I might not agree with the BMA's strike action, but I do accept they have a right to strike. I do accept they've followed the rules in order to go on strike. What I cannot fathom is how any doctor in good conscience would make it harder for managers to make sure we have safe staffing levels, would make it harder for other staff who are going to be turning up to work that day, not least the staff who have not had a higher percentage pay rise, many of whom are paid less than resident doctors. So I just think the BMA's approach to this from start to finish has been completely wrong. They started off a year ago with an incoming government that had an enormous amount of goodwill towards them. enormous amount of sympathy for the arguments they were making, and work quickly to resolve those strikes. And not just a deal to end those strikes, but the opening up of a partnership where we could work together to improve the NHS. And instead of working in partnership, they've chosen confrontation. It's not too late, even at this late stage, for us to get back on the path I wanted us to be on, of working together, of driving real improvements for resident doctors and for patients, but it is going to require a different mindset. The government's changed, the policy's changed, it's time for the BMA's tactics to change. And the idea that doctors would go on strike without informing their employer, not allowing planning for safe staffing, I think is unconscionable, and I would urge resident doctors who are taking part in strike action to do the right thing, as I'm sure many of them will. Jim?
I better just check with the chair, because I'm out of my allotted time, Jim.
No, you've got another 51, 52.
Bring Jim in then on that one.
Yeah, so
Thank you.
just to add to that, I lived through this as a trust chief exec, in the last few rounds of it. It's first of all to reiterate what Secretary of State said. Everybody respects the right to strike, but this is hugely disruptive, much more disruptive than we've been able to describe so far. I've worked with all the consultant colleagues at the end of a week when they've been working very, very long hours through the night to keep the service going. I've met with families who've had diagnostic processes cancelled 3 or 4 times because of strikes. And a lot of this narrow definition about what's technically necessary, I don't accept. It's not that straightforward, and we won't be accepting that kind of process this time. So really hope that this is avoidable. But we also can't allow this to play out in the way that it did last time, with a huge impact on people's lives, colleagues working in the service, a cancellation and a disruption of clinical pathways that is very hard to quantify the impact on. So I would just say, let's not just get too focused on the impact on the elective list. There's a whole range of other disruption that comes with this that we must avoid at all costs.
Thank you.
Thank you, and thank you for that line of questioning. Can I move swiftly over to Greg, please?
Thank you very much, Madam Chairman, and good afternoon, Secretary of State. Unfortunately, I shall be continuing some of the line of the questioning. Can I characterise your view, therefore, on the strikes, that the strikes prior to the general election were reasonable, whereas the ones after the general election were unreasonable? Just a yes or no.
Well, I felt that the previous government was unreasonable by refusing to sit down and negotiate with the BMA for extended periods of time.
Yes?
I think the strikes before the general election were avoidable.
So what do you think has changed with the BMA to change them from a reasonable organisation to an unreasonable one? I suppose what I'm saying is, what have you done or not done?
Oh, I didn't say the BMA were entirely reasonable throughout the entire period.
Well, what have you done? What have you done?
Keeping with their history, but
what have you done or not done, Secretary of State, that has made them come to this point of view?
Well, look, as far as I'm concerned, we've done the right thing. We came in. The strikes have been ongoing for a considerable period of time, at great cost to the taxpayer and at great cost to patients. We recognise the arguments that they've been making about pay erosion and about the conditions that resident doctors were working in, and we recognised the pressure they were feeling as doctors at a particularly early stage in their careers. And so I was proud of the deal that we did last year, proud of the decision we took again this year to implement the recommendation of the pay review body. Taken together, that's a 28.9% pay increase. And I would have expected, not unreasonably, that the BMA and resident doctors would think, okay, we might not have got everything we asked for, but we've moved considerably in the right direction, and this is a government we can do business with, as other trade unions do. We are, in the Labour Party, we're used to dealing with trade unions. Our history is anchored in the trade union movement, and we don't always agree with trade unions, even those affiliated with the Labour Party, but we do understand the value of trade unionism and the importance of deals and bargaining. But I don't see a reasonable kind of trade union partner in the RDC section of the BMA at this time, and I hope
but isn't that
will
part
change.
of the problem, Secretary of State? Isn't the problem that you gave them an massively inflation-busting pay rise, you asked no increase in productivity or efficiency from them, so essentially they've just come back for more? Do you accept no responsibility whatsoever for the position we're now in?
Well, firstly, I don't hold resident doctors responsible for the sort of productivity challenges we have in the NHS. I think actually there are many aspects of the way that they are treated at work which are fundamentally unproductive. So I don't regret the deal that we struck with resident doctors. I do regret that they are in danger of squandering the opportunity of partnership in favour of a more adversarial approach, which is unnecessary, and I fear will prove self-defeating, because if these strikes go ahead, with the financial costs that are entailed, not to mention the misery inflicted on patients, we have to find that money from somewhere, and that will come at the expense of things that they value.
I think you've made that point clearly, Secretary, and I think I suggest we all agree with that point of view. In December 2023, you noted that the then government was giving a higher pay rise to doctors than it was to nurses, and you said it was, and I quote, completely wrong, a slap in the face to nurses, and it seems to me fundamentally unfair. So if the nurses went on strike, would they be being reasonable or unreasonable?
Well, I hope that we're not going to get to that position with nurses, not least because we do have a reasonable dialogue and relationship with the Royal College of Nursing, Unison, and others in the agenda for change.
I hope we don't get there either, but if we do get there, Secretary of State, would they be being reasonable or unreasonable, given your own previous comments on this issue?
Well, we're working with those unions on agenda for change, pay structure reform. That's what we've agreed to do. I think so long as we fulfil our end of the bargain, then everyone will be happy and we can move forward building on that progress. If this government breaks its commitment to nurses and agenda for change staff, I think they would be rightly and justifiably angry, which is why we're not going to do that.
So, given that, as we heard in front of this committee some months ago from the then CFO of NHS England, most of the amount of money that's been put in this last budget was eaten up by pay rises, inflation, drug costs, etc., and therefore there isn't a vast amount of money left. Will you commit to having no above inflation increases to any health staff during this Parliament?
Well, we firstly have an independent pay review body process. I think that process is working largely well. I recognise that trade unions have a number of criticism about the way the process works, and I'm always happy to talk to them about how the process could be better. I thought, for example, the criticism that the PRBs reported far too late in the year was not just frustration felt by unions, but felt by me too, which is why
I suppose what I'm trying to get to, Secretary, is what your view on this is. I mean, I understand the processes, but what's your view? Do you think the public sector NHS staff should get an above inflation increase over the next few years or not?
Well, we always take into account the recommendations of the pay review body. What I would say to NHS staff is the best way for us to be able to deal with the pay erosion they've suffered over many years, and to make sure that we have a competitive rate of pay for NHS staff and a decent standard of living for all of our staff, is to make sure that on reform and productivity we're going as hard and as fast as we can. And that's why we've had to make some decisions on things like the abolition of NHS England and bringing ICBs and systems back to balance, which at the moment are causing considerable pain for people involved in that decision-making process. And anxiety,
I don't need to cut you off.
That's why we have to make some of those choices.
A small amount of time. I want to ask you about one other subject. So the DASI report, the EU Commission said the dire state of social care is among the reasons that the NHS is in a critical condition, and you said at the Labour Party conference there is no solution to the crisis in the NHS that doesn't include a solution for social care. So why has there been really pretty much no inclusion of social care in this 10-year plan?
I don't quite accept that characterisation. So social care features insofar as it impacts on the NHS. So we would envisage social care being part of the neighbourhood health ecosystem. Much of the care delivered in people's homes will involve partnership with social care. In fact, we want to upskill the social care workforce to be able to undertake certain health tasks that we think under proper training they could undertake, would have to be supported with better pay. Delayed discharges, really big role for social care to play, and I would expect NHS organisations to look, when commissioning intermediate care accommodation for admission avoidance and accelerated discharge, that we'd be buying more capacity with and through social care. So that's how social care featured in the 10-year plan. But of course there is a Casey Commission. Report 1 is out next year, and then the second report will be out subsequent to that to set out the long-term direction.
Well, that nicely brings me on to the Age UK, what Age UK have said, and they say delaying the process of comprehensive social care reform will only make it harder to restore the NHS back to health in this Parliament or even the next. Don't you accept, as Age UK seem to be suggesting, that kicking social care to the end of this Parliament by increasing national insurance contributions on the vast proportion of the social care sector is actually hindering social care and therefore will have an impact on how deliverable your 10-year plan is?
Well, I don't agree with kick the can down. Since coming into government, and we've only been in a year, we have increased the spending power in social care significantly. We have delivered the biggest expansion of the carers allowance since the 1970s, a big increase in the disabled facilities grant. We've legislated for fair pay agreements. The Deputy Prime Minister and I will be setting out shortly how they will work in practice and how we're going to roll them out. So that's quite major improvement. I'm not pretending for a moment it's a panacea. I'm not pretending for a moment it's a panacea, but those are meaningful, demonstrable steps in the right direction, and there is more to come.
I will. I'll leave it there because I'm sure the chair wants to come in. Final question from me. I have a number of health-related concerns within my constituency of Farnham and Borden. Will you be willing to come and meet some of the doctors and patients in my constituency to hear their concerns?
If the diary allows.
I'll take that as a maybe. Thank you very much, Chairman.
Not that in there, Jeff. Okay, over to you, Ben. Thank you, Jeff, for your line of questioning.
Secretary of
Over
State,
to you, Ben.
Secretary of State and Jim and Sally, thank you very much for coming today. And this has been a fascinating read, and also a nice read in large print, which makes a change. The Secretary of Government document actually makes it easier to read. I just want to talk a little bit about equality, and particularly race inequalities and inequity as well, which of course is different from inequality. It's excellent that the 10-year plan references inequalities and to see the determination to improve matters there. But it says relatively little when it comes to ethnic or race inequalities. And you'll be aware that we've been looking at this as a committee. The work we've been doing on maternal health, it shows quite serious differences. More black women die in childbirth, as the 10-year health plan references. More black children die in childbirth, at least twice as many. There are lots of examples of that. Do you think that there should be more in the implementation plan which you're bringing out about tackling racial inequality, particularly structural racism in the NHS, than there is in the 10-year plan itself?
Yes, I mean, I think unfortunately this is a huge issue in the NHS at every level. If you look at the experiences of Black and Asian staff, if you look at the experiences of Black and Asian patients, even adjusting for class inequalities and social determinants, we are seeing unequal outcomes for patients. We're seeing bullying of staff, which actually, when you think about how long we've had Black and Asian staff in the NHS since the beginning of the NHS, I think it's just completely intolerable. We don't have enough Black and Asian faces around executive and non-executive boards across the NHS, and that culture flows right down. In the work that I've been doing on maternity, obviously the black maternal mortality gap has been well publicised, and should be no less shocking to us now than the fact we've become used to those statistics. But what I was really, really shocked by, talking to some of the victims of NHS maternity scandals, were the patients who described, and patients and survivors, I should say, being described as a kind of a problem. One woman told me that she had been told, well, I thought you were a strong black woman, as an excuse for the fact she hadn't received enough pain relief. Yep. Asian women described as divas. And so, yes, there are health inequalities that need to be tackled, and some of that is about public policy, some of it is about social determinants, and the wider inequalities and things like genetics, disposition to certain disease and all the rest of it. We've got to deal with that using good science and good quality care, but that does not explain just the overt as well as unintended or unconscious racism that we see in the NHS.
So given that, and it's very interesting you talk about within the NHS, and I've been looking at the figures for the staff surveys which are published for 150 NHS organisations over the last few years. And it is quite shocking because the figures for 2022 on whether you feel that you have had fair career progression, whether you've been discriminated against by patients, whether you've actually, or other members of the public, whether you've been discriminated against by other members of staff, have actually got worse in the last 2 years. Jim, is this something you recognise and something that you have ideas about how you want to tackle it?
Yeah, absolutely. So this will be something we really want to elevate in this next phase. So from a staff satisfaction perspective, but also patient satisfaction perspective, and try to get behind these metrics and really understand what's driving concerns and how people feel.
Do you think, given the fact that the figures have got a little bit worse over the last 2 years, and actually all the time I've been looking at it, which over a number of years, they get a little bit worse each year. Do you think the NHS doesn't have an idea how to tackle it? And if you do, what would you think it could do differently?
I think pockets of the NHS have. I think there is evidence where organisations have been very systematic about understanding the data, really tailoring that to local actions that really address the specific issues there. There is evidence that has worked. It hasn't worked absolutely across the board, and we will absolutely be trying to do that and scale that across the NHS.
I see. So I'm sorry, Wes, forgive me. I saw Sally nodding vigorously there. I just thought maybe she could come in.
Yeah, thank you. So I think particularly when it comes to workforce race equality, there's really good examples where local trusts have tackled and made improvements on 2 or 3 metrics, but they've not been able to shift that to improvement across all of the metrics. So I think there's a task for us nationally to help share best practice. Some of that's about networks, some of it's about leadership programs, so that there's lots of activity that has been proven to work. It's just about how do we scale that across all of our local trusts.
And I was just going to add briefly, this is where I think we need to reform our approach to diversity, equality and inclusion. There's a kind of school of thought that says anything that's spent on DEI is sort of like dead weight costs, wasteful, get it out of the NHS. As we can see through the black maternal mortality gap, or you can see in other areas like mental health, inequality can be a matter of life and death, and it should be the NHS's core business to tackle health inequalities. I think, therefore, we both need to reform our approach to equality, diversity and inclusion within the NHS, and also hold people to account for outcomes, not just inputs and workshops and posters and all manner of other things that people are doing, because it should not be the case in this decade of the 21st century that black women are 3 or 4 times more likely to die in childbirth than white women, or black men are twice as likely to die of prostate cancer than white men.
Absolutely, and obviously it is just simply wrong, it is cruel, it is poor, it's also expensive. And I wondered if this is an area which the NHS RHO has been looking at, the Race and Health Observatory has been looking at, but they've been looking at the cost, the economic cost of racism. And for example, in maternity care, if you get women dying 3 times a year, £1.6 billion compensation is paid out for maternity-related cases every year. In mental health, where black men are 3 times as likely to be detained under the Mental Health Act, or say 8 times as likely to get a community treatment order, they will cost the NHS, this will cost the NHS some £11,000 to £12,000 a year. A white person's costing £5,000 a year. I don't think it's intrinsically the colour of the skin that makes people behave differently. I think it's the way that people are treated that's costing the NHS a lot of money. The workforce, bullying and harassment costs £2.3 billion a year, huge amount of money. Again, it's a particular risk if you're a black and minority ethnic background. There's all sorts of other areas. So the idea of taking what the NHS 10-year plan says about allocating NHS money more effectively to better maximise, split infinitive, but it's in the paper, to better maximise return, is part of maximising your return better, doing a proper cost analysis of the economic cost of structural racism in the NHS.
Yes, but I'd also say, because I think sometimes when you illustrate the the cost to the economy as a whole, that can be really helpful in terms of elevating something as a priority and kind of demonstrating the impact that it would have if we solved X problem on, the cost to the economy. But I think even more powerfully in an NHS context, we can kind of demonstrate the actual cash price of failure. You just did it in maternity. I mean, it is shocking that we're spending more on maternity claims than we are on maternity service improvements. It's kind of no-brainer to me that we need to shift a number of these things in the right direction, not least because it's better value for money, but most importantly of all, because everyone in our country, whoever they are, whatever their background, deserves access to high quality, safe care where they feel safe and respected. That should be a service that is available to everyone, and the people working in the service should also feel that they are able to bring themselves, their whole selves to work, and that they should not be discriminated against because of who they are.
So you'll be looking at the actual costs that you could save at the same time by not just dealing with racism because it's iniquitous, and no matter what other parties on the right of us say about not doing diversity issues, it's clearly highly inefficient because it costs the NHS a lot of money, taking a very stark view at a time when we have been left with empty cupboards wherever we look. Just talking about the Cahill deprivation formula, and you're going to have another look at that, and that could lead to a different approach towards deprivation. Is that going to be on the basis of geographical deprivation? Are you also going to take racial issues into account, some of the challenges facing ethnic minorities, obviously who often come from poorer communities and are spread around the country, not just in specific areas? So will race equity be part of your Cahill review?
Well, we're going to consult on Cahill, and I think it would be a reasonable thing for people to ask us to look at, and we'll take that into consideration.
Will you take that into consideration?
The real thing we're driving at is to make sure that the level of resource going into general practice is able to meet the needs of the local population. And so you've got to take into account a whole range of demographic pressures and societal conditions on the health need and demand, Sally.
Yeah. So we've also said we're going to ask the Advisory Committee on Resource Allocation to look again at our overall formulas for allocations to integrated care boards, and we want to look there at a whole host of factors that can drive health needs. So some of that will be geography, some of it will be economic circumstances, but there will be a lot around coastal communities, for example. We know there's higher health need, we know that there'll be different health need from different ethnic communities, so we want to look at the best possible evidence base to then have a new formula that reflects current and future need for health.
No doubt we can come back and discuss whether we think your approach is right and it's a necessary thing. Final quick question, slightly different thing, neighbourhoods. A question about who's going to lead these locally. It could be GPs, it could be hospitals, it could be NHS trusts, it could be private companies. Yes? All those are possibilities?
In terms of neighbourhood health services, we would anticipate these would be mainly NHS organisations, but you could imagine, with some of the things that we want to achieve, that we'll be working with people like Boots and Specsavers to deliver a greater range of services as well.
But led by NHS?
Yeah, always led by the NHS.
And that's going to require extra resource for whoever's doing it. It's quite a management job, running a neighbourhood health service. Is there going to be extra resource given to whoever's actually managing it, whichever part of the NHS they're doing it from? Or are they going to be expected to manage it and set up these new neighbourhood centres within the existing budgets?
Well, I think there's two different things. There's neighbourhood health, and in terms of, leadership of kind of the needs of the local population, and then there's neighbourhood health centres. So in terms of neighbourhood health models, of course, with any new provider organisation, you would obviously, they'd obviously be commissioned and established with a level of management resource to be able to undertake the duties that they're taking on. Neighbourhood health centres, we have done two things. One is we've got the largest capital allocation the NHS has ever had. That gets us some of the way in terms of meeting the capital needs and pressures on the NHS, but we need to go further. The Darcy Commission identified, I think, undercapitalisation about £37 billion with the best will in the world, and even if the Chancellor is able to find more public resources available for us, I don't think we can anticipate over the course of this spending review or over the course of this Parliament that it would be sufficient to deal with all of that undercapitalisation that Darcy diagnosed. So we do need to look at alternative private investment options. That was in the government's infrastructure plan as far as neighbourhood health is concerned. We are treading cautiously. Proud though I am of the record of the last Labour government and what it did to waiting times and patient satisfaction. PFI led to large costs and in some cases very poor value. And
very poor contract management. We need to improve contract management.
Contract management.
Thank you very much.
Thank you. So we need to make sure we learn those lessons and get this absolutely right, Jim.
And just to add on that, from a management leadership point of view, what we've been trying to do, as Secretary of State said, is shift the leadership focus up through the chain into the centre and more local. So there may be some additional management resource short term to help develop neighbourhoods, but the idea is it'll be more productive management time over time spent locally rather than through an oversight and assurance process.
Thank you for that, and thank you for that, Ben. Can I hand swiftly over to Danny, please?
Thank you very much. Thank you, Secretary of State. Just to follow up on that question, I was going to ask about capital spending in the health service and as part of the 10-year plan. In terms of the NHS neighbourhood hubs, will there be any specific capital investment to enable the rollout of neighbourhood hubs, or is this solely leaning on a future?
Yeah, we've committed during this Parliament to sort of 40 to 50 neighbourhood health centres. We think we can roll out during that period. If we are able to leverage in more external investment, then obviously our capability and capacity to do more is better.
That's without private sector investment, the 40 to 50?
Yep.
Fantastic. And there'll be specific capital funding available centrally to enable, when just be local systems under them. That's helpful. And in the PPPs, learning the lessons of PFIs, you've touched upon it slightly. What will be the kind of assurance process of local agreements? Will the department provide kind of very clear guidance to avoid the contracting mistakes that we saw under PFI?
Yes, so we'll be setting out some clear rules and frameworks that people can work within, specifically addressing the issues from the past and over time, model contracts, model approaches, those sorts of things. So we don't replicate things all of the time, but that will be something that will be developed over the summer. Also, just in addition, as well as PPP or traditional capital, what a lot of people are finding is there's a really good council facility, or there's an already quite new health centre that could be reallocated and redeveloped as part of this thing. So what we want to try and do is nurture all of these things at the same time, as long as it delivers on the principles and the outcomes we expect.
Well, thank you. And the plan talks about private financing of revenue generating assets, so car parks, other kind of facilities, energy facilities. Will we expect increasing patient charges for car parks, for food, for other associated goods to enable this capital investment?
Expect that.
So you're kind of confident that patient charging through these other routes won't be
seeking to shift the cost of this onto patients, but this is a really important thing to open up. There's an awful lot of commercial appetite out there in the NHS for the development of, say, pharmaceutical production or laundry services. One of the things that was being explored in the northeast before I came to do this job. So there's an awful lot of stuff there where there's a potential market opportunity. Was previously constrained under the old rules and now is possible under these rules.
Thank you. And so we've seen strategic health authorities and PCTs become CCGs and ICSs, then ICBs. Now we've got ICBs kind of light plus ICOs. Do you think the structures are suitably different to drive different outcomes? Do you think the fundamental issues about financial flows and incentives to prevention are significant enough? Do you feel the role of public health and social care are strong enough in the new structures?
Yeah, I do.
So I think throughout this discussion we've come back through history at various points when we've tried some of this in different ways, and it's either worked or hasn't worked, or worked for short periods. There are really strong common principles. These are the financial incentives, a devolved system, clear rules-based system, but also the clarity that you have to work with local partners, whoever those local partners are, and sometimes you know, there's a really strong voluntary sector or independent sector, or you've got a specific housing issue or social justice issue.
There's always public health and there's always social care. What would make them work?
They should absolutely be at the table and be really key partners in all of this. The extent to which...
Different to PCTs, then ICBs through ICPs. Is that different?
So in some of those previous incarnations, the involvement meant representation on a board or in some form of governance system. What we're trying to say here is work with partners actively. Don't just address it in the governance system.
Because
sorry?
That sounds quite similar to person on a board to me. How will it look different to a person on a board?
I'm talking about operational, clinical, social care colleagues, practical people on the ground working within a set of rules.
They will have to work together operationally and in terms of...
It's about working at every level and my point is it's not done when you've appointed somebody into a board. This has got to work right the way through the system and be less bothered about who works for who, but more about what they're delivering for people.
And I want to see, in terms of the development of neighbourhood kind of health and care plans, I want to see people working together to develop those plans and sign them off together in a spirit of partnership, because I think it's fair to say, and having sat in different parts of this system over the years, the NHS always feels like the big beast at the table. Some NHS organisations are better at partnering with their voluntary and sector and their local government partners than others, but it should be like close working, mutual respect and partnership should be the norm, not the exception.
I certainly agree with that. In terms of patient power payments on financial incentives, what would stop under patient power payments sync hospitals developing or sync services which are already struggling financially? Patients then move their care or seek to move their patient power payment to bigger trusts, more successful trusts. How does that go kind of with the spirit of ensuring areas of deprivation get better services, not worse services?
So the first thing to say is we're going to trial this approach initially because it's never been done before, and on something like this, I wouldn't want to just roll this out across the NHS without making sure there aren't unintended consequences. But the purpose behind it is to give the patient real bite in the system. At the moment, it is extremely easy to dismiss and ignore patient complaints and concerns. And I've seen that in the most egregious cases of families who've been failed in the most appalling way in maternity services, in mental health services. I've spent a lot of time in the last year meeting with people I would characterise as victims of the NHS. Now, that's...
Is a payment, sorry to interrupt, because of time short,
yeah.
Is a payment penalty enough to change that, or is it a change of leadership, a change of culture, investment?
Well, I think ultimately, in terms of performance improvement, it's a range of levers and it's a range of consequences.
You guarantee that there won't be sync hospitals and sync services that see their funding just slashed further, or they're struggling potentially in maternity services?
But the money isn't pulled all the way completely. It will go into a sort of patient improvement fund. And, you know, everyone from ICBs to NHS regions have oversight of services and financial performance as well as quality and safety. So there are checks and balances in place. But what this will enable us to do, if it works as I intend, will be for patients to hit NHS providers where it hurts, because money talks in this system. And in doing so, that will send a signal up to us if we're spotting a whole number of patients in a particular part of the country are exercising that right to withhold payment for a particular service and put it into a more general pot. I must say that's not my big fear with this system. My fear is that it'll be a bit like someone who gets a ropey Uber driver who's taken them round the wrong route, but thinks, well, if I give them anything less than 5 stars, I'm going to get them in trouble, so it gives them a 5-star rating. I actually think there's more likely to be that kind of kindness bias in this system than the opposite, but we'll see, and that's why I want to trial it. I want to give patients more kind of genuine power in this system and choice, convenience, ease, like those are all sorts of things that patients will get through the app. They will feel an improvement to their experience, but I also want to give patients more bite.
On the app, a huge amount relies on digital transformation in terms of driving productivity improvements. The 10-year plan talks about bringing the NHS into the digital age. Who will be accountable for the digital transformation? Who will lead the digital transformation? Will the functions that were NHS Digital in NHS England transition to DH? Will resources maintain the same at that function?
Yeah, Jim, do you want to say more about
Yes, so we're working through that currently. The current plan is they will transfer as functions and be into the transfer into the DHSC.
They'll be equally resourced as they are now.
Well, everything is subject to the cost reduction that's already been announced.
How will we do more? How will we drive a digital NHS if we see less staff working in digital functions? I think we've heard ICBs also reducing headcounts by 50%. Providers are often discussed as potentially leading digital transformation, but many of them are being pushed to deliver more frontline staffing, and usually digital isn't considered as frontline staffing. I think the business committee recently heard a session about NHS Digital. Around 3% of staff in the whole health service are in digital functions. Do you imagine that that 3% across central, regional and local systems will go up, will stay the same?
So everything is going to have to be challenged. There isn't part of the health service we can say you're absolutely 100% protected from a cost-saving point of view, given the overall position. We absolutely want to be sensitive and understand need and not shrink something when it actually is going to disable capability and capacity going forward. We also know that there's huge variation right across the system in terms of what people are currently investing in all of this. So the short answer is we can either say it's a straight 50% everywhere, or those things are completely protected, because it's just much more complicated than that.
And we've got, don't forget, we've got £10 billion has been allocated in the spending review.
Which is really welcome, but in terms of delivering that capital investment, if staff in the NHS are cut dramatically at all levels to roll out that capital spending, are you not worried that we might see more poor private sector contracting for digital products, more reliance on contracting and failed IT projects of old?
I wouldn't anticipate staff in this area being cut dramatically in the way that you suggest. I think Jim is absolutely right. You know, in terms of the design of the new organisation, we want to reduce overall headcount by 50%. That's not the same as taking 50% out of every team and function. And clearly this is an area that is absolutely critical from, you know, a health security point of view, system delivery point of view, and, you know, future transformation point of view.
Thank you so much, Secretary of State.
Thank you, Danny. And can I go straight over to Andrew, please?
Thank you very much. I want you to succeed. I want this to succeed. The values are unarguable. I think the shifts make a lot of sense. I mean, no one would argue that we need to shift from prevention to sickness, and therefore, you know, we want the process to succeed. In the case of shifting from hospital to community, I just wonder whether, well, the question is how, and it's like changing the wheels on a moving bus, really. I mean, how can you do that when at present we know there is the pervasive problem of corridor care, of ambulances queuing, of avoidable deaths in emergency departments as a result of the pressures at that level? I mean, how can you take resources away, which is, I think, is in effect what you're proposing, whilst also making sure that the services are stable enough? Don't you need to double run to a certain extent?
So the two problems you described are inextricably linked. And so, you know, what we'll be doing over time is driving the left shift, not just in terms of transfer of resources, but also transfer of responsibilities. So there are lots of things from diagnostic tests and scans through to minor injuries and urgent treatment that can and should be done in primary and community care, as far as I'm concerned. There are also areas where we can and should make savings in hospital care, particularly in terms of outpatient appointments, where we want to significantly reduce the pointless activity that takes place in outpatients, and also to deliver more outpatient care where it is needed, to make sure it's delivered close to people's homes or indeed in people's homes, which will be more easy and convenient. I mean, we're only a year in, but we have already started to signal what that shift looks like with £889 million into the GP contract, the employment of additional 1,900 GPs. We are beginning that left shift. It is going to take time, and one of the virtues of having a 10-year plan is you do these things in a managed and orderly way rather than a disruptive and, worse still, self-defeating or destructive kind of way.
And you believe that it's possible in relation to the emergency entrance into the hospital, which is the one which I was referring to.
Yeah.
You're content that can be managed, and the crisis, we have to call it a crisis, it's still a crisis. It's not your fault. You've inherited it. It's a difficult one to overcome, but you think that we can get on top of that at the same time as you're doing everything else.
Well, there are lots of people who are presenting in emergency care who do not require emergency care, and I don't criticise those patients because often it's the only place they feel they can access. But there are lots of things that the NHS is doing that, if rolled out consistently, would make a massive difference. For example, hear and treat services, when people are phoning up for an ambulance, being triaged on the phone, and often, as I saw actually with Jim's predecessor Amanda Pritchard up in the northeast on Teesside, instead of waiting hours for an ambulance that when it turns up is probably a little bit grumpy even if they don't show it because they think you didn't need to see me, someone else could have done this, they had a community response car out from the community-based team, much faster, so better experience for patients but also better use of taxpayers' money. So I think the more we can get people the right care in the right place at the right time, the less likely they are to unnecessarily and avoidably call on emergency services, which then frees up those emergency services to do the things that only they can do. Finally, since you mentioned corridor care, I just wanted to inform the committee that we are shortly going to be publishing data on the number of corridor care beds. Because I think sunlight is the best disinfectant, and we have to be honest about the scale of the challenge so that you can hold me to account for improving the situation and I can hold the system to account for improving the situation.
That's helpful. Moving it on, and we'll monitor that as time goes on. Moving on, you mentioned that patients can be treated, and you've dealt with a number of cases where they've been treated egregiously, I think was the term that you used. To what extent? I mean, I'm looking at chapter 7 of the document. To what extent do you think that there needs to be more in relation to mandated safe staffing levels? I mean, for example, we know that beneath all of the heat and fury of the mid-staff's inquiry reports was chronic, unsafe staffing levels in many of those contexts. So to what extent do you think that there needs to be established mandated, registered clinician staffing levels?
I'd say a few things and bring in Jim as well, and Sally. So firstly, when it comes to thinking about quality and safety, kind of mid-staffs looms large in my mind, and the lessons of that inquiry, and also the conversations I've had with a significant number of families over the last 12 months, which have been by far and away the best and worst meetings I have sat through, best in terms of the insight, worst in terms of how harrowing and distressing some of the stories I've heard have been. I think there are lots of tools we have available to us now which we didn't have when we were last in government, in terms of the quality of the data that's available, how we can use that to do much better early warning where things are going wrong, or where you can see patterns in patient experience that might point to a deeper problem and you might want to send a team in. We are also, thanks to the work of Penny Dash, looking to streamline regulation so that the people who are regulated know the rules that they're working to and can discharge safer care because they've got much clearer marching orders, and we can better assess their performance against those, reforming the CQC. So there are a whole number of things we can do on quality. On safe staffing levels, I think it's really important that we work with the professions and look at each clinical pathway and look at what safe staffing levels mean in each case, at the same time as recognising that this isn't going to be static. There are all sorts of improvements in medical science, technology. There are a growing number of roles, and obviously we are doing a bit of first principles thinking on that at the moment, and we'll be publishing the Lang Review shortly in relation to medical associate roles, for example. But I think we have to kind of make sure we're, by all means, discussing and debating safe staffing levels, but following the evidence as we do so as well.
If I may move on, just one area where I think safe staffing is important, and that is nurses. And you mentioned that earlier, and you've heard the RCN were talking about their pay and conditions today. And obviously I know that, Sally, you come from a nursing background yourself, that very often you'll have people who go into nursing who commit their whole careers to it and finish on band 5, which can be at the top of the spine at £37,000. I mean, someone who's committed their lives to that profession and to end up at that level. Do you think that is sufficient? The majority of them, end up in that situation. I mean, in Chapter 7 you talk about recruitment and how to recruit, but it's retaining nurses is the big problem. I mean, they're leaving in their droves, and no wonder.
Yeah, that's right. And I'm anxious about this. I don't think our nursing profession have received the level of respect and support to which they are entitled, and unless we give nurses better job security, better job satisfaction, and unless they feel genuinely recognised and rewarded for the work they're doing, we end up, in the worst of all worlds, of investing a lot in their training and then losing all of that knowledge and experience when they go elsewhere. And we are working, in fact the Chief Nursing Officer for England is working with the professions to develop a strategy that will make nursing and midwifery modern careers of choice to address the decline in applications to education programmes. And we have committed to RCN, Unison and others reform of the Agenda for Change structure, which I think would make a real difference. And we also want to see opportunities like consultant nurses, nurses as leaders in their own right. So I think the future for the profession is bright, but as with most things in this job, going back to July 2024, not necessarily where I would have wanted to start from.
No, of course. And, I mean, that's all in the report, but just final question.
Andrew, it's 37, you've got a minute.
Okay, final question. In my area, the social care contracts, both NHS and the local authority, are proposing to pay social care workers £12.79 an hour, irrespective of whether it be holiday, unsocial hours or any other. I mean, we know that the national living wage is £2.21.
Andrew, ask your question.
How can we possibly fill those contracts when the service itself isn't prepared to pay for it?
It is the thing that unites the employers, the trade unions and the local authorities. Unless we pay our care staff better and unless we build a genuine social care profession, we are going to fail to recruit and retain the brilliant people we need. That's why fair pay agreements were introduced on the face of the Employment Rights Bill in the first 100 days. That's making its way through Parliament, and Deputy Prime Minister and I will shortly be setting out how they're going to work in practice and the funding attached to it.
Place to stop there, please, Wes. Can I go straight over? Thank you, Andrew. And can I go straight over to Josh? Thank you.
Thank you, Secretary of State. I'm going to talk a bit about the kind of career progression of doctors and kind of training routes, if that's okay. So in 2012, 66% of doctors who completed foundation training, so F2, would go straight on to a specialty training programme. That's shifted, so now it's 22%. Obviously, that's a huge shift in the medical workforce, and some of that is driven by the fact we don't have enough training places. You've said you're going to get 1,000 new training places over 3 years. Is that enough?
Yes, if I can go further, I'd like to. I mean, notwithstanding, I don't agree with the BMA about the timing of their proposed strike action or the necessity of their proposed strike action, but not just the concern, the anger and frustration that I hear from resident doctors, I absolutely share. And as I've said to many of them, the best pay rise that they can get is going from being a resident doctor to a consultant. That if we can deal with the bottlenecks issue, that will be better for them, better for patients and the NHS, because we need more of that clinical leadership capability.
So we're now also seeing just a massive increase in the number of doctors going on to SAS and LE contracts. Is the answer to that a more formal role for SAS and LE doctors, or is it to get training sorted and to get other routes onto the medical register?
No, I think you're right. We've got our workforce plan that we're currently developing in light of the 10-year plan. The previous workforce plan just wasn't in the right place. A number of its assumptions were flawed. If we continue the rate of growth that the long-term workforce plan had assumed, then by the end of the century 100% of our population would need to work in the NHS. I think we can all agree is implausible, to say something else then. And so therefore we are developing a workforce plan that aligns with the strategic direction set out by the 10-year plan. And I think that also offers us an opportunity to deal with some of these thorny issues that just haven't been dealt with and have led to resentment in the profession. Sally? Oh, sorry.
I mean, I get that, but I'm just trying to work out kind of what does our doctor population look like? Because I mean, we all know that resident doctors deliver most of the care, as do SAS and LE doctors. So what does it look like? Are we going to have a greater proportion of SAS and LE doctors, or are we going to get the SAS and LE doctors into formal programmes through into being kind of at a higher level of training and being...
You're tempting me to preempt the workforce plan. But those are exactly the sorts of questions we need to address. Yeah. It's like the size, the shape, the capacity, the capability of the future workforce.
Yeah. There was a brief mention in the 10-year plan about simplifying routes for SAS and LE doctors onto the medical register. I think last year 276 doctors went through what used to be the CSER-SEGPA route. Is that the right kind of number, or do you think that we should make it easier for SAS doctors to become?
We do need to make it easier and simpler, and again that's something we'll be looking at in the context of the workforce plan. I mean, we also need to look carefully at the diversity of the medical workforce. And I don't just mean doctors, but if we take medicine specifically, it is still the case that too many people who are signing on to medicine course at university are from the sort of backgrounds of sons and daughters of doctors, and we do need to make access to medicine more open to working class students from backgrounds like mine, and not just to preserve of people who can afford it. And similarly, thinking about the broader NHS workforce, one of the great tragedies, particularly in nursing and midwifery, is a lot of people who've reached a stage in their life where they might have a career change. Maybe they've been doing some caring for younger relatives or older relatives. Think I'm now going to go into nursing, or I'm going to go into midwifery. They're not doing it. So we've got to deal with some of these disincentives, because we're losing a lot of people with really valuable life experience from going into a whole range of NHS professions.
Do you think part of that, some of the assumptions baked into NHS contracts? So 60% of doctors who've just qualified are women, which is compared to a medical workforce where they make about 49%, so you can tell like it's kind of skewed younger. Is that just because it's not flexible enough?
Yeah, and I was thinking back to the big row that Jeremy Hunt had with the BMA over 7-day working. And that argument looks so kind of dated now, because I think lots of people, not just in the NHS, but particularly in the NHS, would like more flexible working. And one of the reasons why we've seen agency costs shoot up is because people have seen kind of agency work as the only way to get a career that fits around their lives. And that's worse for them because they don't necessarily know where they're going to be working from one place or one week to the next. And you don't build that sense of camaraderie and teamwork and relationships at work that I think we all value most of the time. It's also not great for the NHS that ends up paying through the nose, or for patients who might not have that kind of continuity, even in a hospital setting where you get to know the clinical team around you. So I think flexible working is a win-win. And again, in contrast to the sort of approach we've seen in the past, I don't think this is something that we need to impose. I think this is something that we need to offer. And I think we'll find staff taking it up in a way that benefits them, benefits the NHS, and most importantly, benefits patients.
We need better flexible training as well, because actually if you think about the point of life at which doctors are in specialty training, and given the majority of women, does training need to be more flexible?
Yeah, I think we do need to look at that. And we also need to make sure that training for all parts of the NHS workforce in all cases is valuable. There's a lot of complaining from NHS staff who feel like they are kind of subjected to a whole load of training that they feel is pointless, and this sort of kind of brings to life really why the idea that NHS staff are opposed to reform is nonsense, or that they're somehow a problem on productivity is a nonsense. Because actually one of the things that staff really complain about in terms of training they're subjected to that they think is pointless is they want to be out seeing their patients, and they know that their time away from clinical practice is valuable time. And so, we've got to make sure that we're using their time effectively and asking them to do things they need to do, genuinely need to do, or offering them development opportunities where we can, rather than subjecting people to training they think is a pointless waste of their time.
And how are we going to make sure we've got people in the roles that we need for the future? Because obviously it's much easier to train a doctor into the specialties that we have at the moment and the specialties where we have more people. But actually, if we're going to have more people, GP training is a particularly difficult one to train the right number. How are we going to incentivise that, and how are we going to get that shift?
Yeah, we do need to look at all of the training routes to make sure that they are relevant to what modern clinical practice will look like and the way in which these roles are going to evolve with medical science and technology. And we've also, I think, part of the challenge with general practice and with district nursing, for example, they've not had the best rep with medical students when thinking about where they're going, or nursing students when thinking about like what they imagine their nursing career to look like, because they've been seen as on the slide or going through a bad time. So if you're reading all the time in the newspapers that GPs are overworked and burned out, and constantly seeing GPs given a kicking because people can't get an appointment, you're not going to think, oh, do you know what, that's where I want to go to work. Or similarly, with district nursing, there's been a sense for some time that part of the profession has sort of been on the wane. And actually, the pitch I want to make to the doctors and nurses of the future, as well as other allied health professionals, is that community, neighbourhood health is where it's at. It's where some of the most exciting medicine will be practiced. It's where you can make the most difference to patients in tackling health inequalities. And I think that will really speak to the values of the generation that's coming through and what they want to achieve. So I hope that we'll see a good deal of enthusiasm for working in general practice or working in community teams as district nurses and all sorts of other roles.
One final question, Secretary of State, and it's a bit from left field, but you said community and neighbourhood health is where it's at. Earlier you said social care will be the the door out of the NHS. We've talked a bit about funding, but actually this report is brilliant, but it is very light on social care, and it points just to the result of the upcoming case review. I don't feel that it grasps the nettle quite. Do you? If you would you like to see it grasp the nettle more, and how can we be confident that between now and the release of the case review, social care is going to be in a better position?
Yeah, well, without reeling off the list I gave earlier, I think things we've done in the first year of this Labour government have been significant and substantial on social care. But I recognise it's against the backdrop of much wider kind of challenge and crisis in the social care system. What you'll see next year from Casey is a kind of set of recommendations and effectively marching orders, because it's Louise Casey, about what we should do for the remainder of this Parliament, and then the long-term reform agenda, which I think involves a much wider national conversation about what we need from social care, how we fund it. That will come following that. So it's not like there won't be other big things going on in social care between now and then. I mean, what we're doing on fair pay agreements is in itself a significant reform. But I do understand.
I don't really know about fair pay agreements. I'm not sure if this is.
Josh.
We'll come back to you on that.
Thank you. Thank you, Josh. Can I go over, these are snap questions, snap answers we're asking for. So, Greg, over to
I'm
you.
least good at.
Well, yes, unfortunately, I doubt you're going to be able to do this in a snap answer, but I look forward to writing to me. So, Jim, in an answer to me earlier, the Secretary of State suggested that he didn't see it being the role of resident doctors to be involved in productivity and efficiency. Is that your take on this, or is there a role for resident doctors in any part of the workforce to be part of that?
I don't think he said that. I think he said we shouldn't blame resident doctors for the productivity problems that the NHS has got. So we've all got a part to play. In our approach to productivity, we'll look at things in the round, the workforce, technology, the estate, etc. All that's in hand. But I don't think he actually said what you've just said.
If I've mischaracterised him, then I apologise. But specifically then, where do you see the workforce playing its role in efficiency and productivity?
So we want the whole of the workforce to engage in the challenge that we've got. We've got a finite amount of money that's on the edge of what the economy can afford. It's a huge growth over recent years, and we've got lots of patients to treat, so we need everybody to lean in and participate in the innovation, the transformation, the pathway changes that we've all got to play, and it's not possible by just the management system pushing it or certain parts of the clinical community pushing it. We've got to try and do it all together.
The best examples of improved productivity in electives, for example, has come from clinical leadership.
I agree.
And frontline clinical leadership. And obviously that includes resident doctors and other NHS staff. So that's what gives me hope actually about the future. I think they are up for the challenge. They want us to kind of take the brakes off.
You would cite an example, maybe the GIRF programme.
Yeah, it's very good.
Very much.
Becky, you came next.
Thank you. You want a snap question,
Snap question, snap answer. Great stuff.
So gambling, Secretary of State, it's currently in DCMS. There is an increasing evidence base that it is incredibly harmful, particularly the more dangerous products online. What do you think about seriously putting it into the Department of Health and looking at it as an addictive, harmful agenda as opposed to an entertainment agenda?
I think gambling's a bit like alcohol in that I don't want to stop people from having a flutter. I don't want to stop people enjoying a pint. But in both alcohol harms and gambling harms, what you see are a minority but not insignificant number of people who experience severe harm. And
just
that's where
pressing
we've got
you wouldn't
to
put
focus.
alcohol in DCMS. Why would you transfer gambling on that? The logic of your argument?
Well, alcohol policy it sort of straddles us and the Home Office, and I think in terms of gambling harms, I have a kind of line of sight into it as the Health and Social Care Secretary, but it sits with DCMS.
For now, thank you, Secretary of State.
Thank you, and Danny, over to you.
Thank you. The committee's looked at child vaccination rates recently. We had a tragic case, an outbreak in the last few days around Alderhay. The 2012 outbreak in Merseyside cost £4.4 million to treat, 20 times the cost of the vaccinations that would have prevented it. The 95% WHO target has not been met. The rates between areas vary, sometimes 30% in vaccination rates. Was it right to downgrade the 95% target? Should it be restored for the system? And are we doing enough to increase child vaccination rates?
I mean, firstly, no child in this country should be dying of measles. And I'm extremely sorry to the poor family that's now grieving the loss of a child in those circumstances. I'm sure everyone will join me in sharing condolences. This is why we have got to redouble our efforts on vaccination and to make the case. Some of the improvements in the 10-year plan will help in terms of having digital records of children's health that parents can check into, the digital red book. That'll be really good. So it means that on moments like, over the weekend where someone's read an awful case in the media, parents can just quickly log on and think, actually, did we get that jab? Are we up to date on our vaccinations? And we can also proactively invite people to vaccination. But we'll be doing a lot more on this throughout the remainder of the year in terms of trying to get vaccination uptake because it saves lives.
We need additional investment and support to get those areas that are 30% below the highest levels of vaccination in the country up to where they should be.
And we do have significant resource already attached to public health information campaigns. What I will do is write to the committee, sort of given the profile of this issue at the moment, to share the work that we'll be doing to drive up vaccination rates. Jim, is there anything you want to add?
No, thank you for that, Danny. Thank you for that. Can I hand over to Ben?
Yes, thank you.
Fire question.
Yeah, the 10-year plan has some dates for when things will happen by. Are you planning to produce a single overview timetable for implementing all the different promises in the plan? And if you are, when will you produce that timetable by?
There are lots of dates throughout the plan. What we can be clear about is what we're doing over the next few years, because that's in the spending review period. Obviously, from one year to the next, you have to revise your financial planning. But overall, we've got a clear set of commitments for the next few years, which is the sort of clear line of sight that I have in terms of the money. Beyond that, we're kind of more into ambition territory. For no other reason than I'm really reluctant to make promises or to indeed to write checks without knowing that I can cash them.
Right. So could you at least pull together everything that's there as a date at the moment and produce a single timetable? It would just be easier for us to deal with and probably everybody else out there as well. Would that be possible?
It's possible, Jim.
So what we're planning on doing is have the NHS produce medium-term plans in the round in the autumn, start in the autumn and complete by Christmas ideally. So that will set out how the NHS takes this plan and all of our other operational imperatives and plan that over a period of time.
It's going to be one of those NHS, I've sat on an ICB for 2 years. Is it going to be a nice, simple 2-pager that we can all read as well as the 350 pages that an ICB would usually require us to plough through?
Hopefully, yeah.
Yeah? Just a couple of pages.
All right.
Thank you.
Thank you, Ben. Andrew, over to you.
It's a lot of homework.
So you made the patient voice a very high priority for you, and not just in terms of patient power in your introductory remarks, but you're scrapping Health Watch. So what are you going to be putting in its place, or to ensure that there's an independent vehicle to ensure that the patient voice can be heard?
Mm-hmm. So I'd say a few things about that. Firstly, I don't doubt for a moment that Health Watch and Health Watches across the country have produced some valuable work over their time. But we're moving into a new phase where patient voice should be embedded throughout the whole system. There are other national organisations in this space, but fundamentally we want to give more power to the patient. Secondly, I'd say as parliamentarians, we've got to stop outsourcing our job to other people. Government is doing it all the time with the proliferation of loads of arm's length bodies that basically say either this is too difficult and too controversial, we don't want to touch it, so we're pushing it out over there, or we don't trust ourselves as politicians, so it's going over there. And the same is true for advocacy for the public. We shouldn't need loads of organisations to speak up on behalf of our residents and citizens. That's our job as parliamentarians and councillors and elected representatives.
Thank you, Andrew. Thank you. Over to me. My last question is about black maternal health. I am passionate about this subject, as you know, Secretary of State. The fact that 3.7 more black women are having poorer outcomes than white women is an issue out there. They've talked about this national maternity investigation. Using the 10-year plan, how are you hoping to address some of these issues? If the question is too much for today, I'm happy for you to write
the first thing I want to do is just reaffirm to you and to the committee that we will have a target in this area for improving the mortality gap, because I think it is so important. And as you know, I'm trying to reduce the number of targets overall, but I think this is extremely important and morally impossible to sort of justify this gap. As part of the national investigation and the work of the task force, we are going to make sure that the inequalities side of maternity failures is absolutely integral to the work that the investigation and then the work of that the task force does. So we'll definitely be coming back to this topic, I know, but I want to reassure you in the committee that the racial inequalities in maternity care and failures in maternity care is going to be absolutely at the heart of the agenda. If we can't get tackling racial inequalities right on maternity, then I don't think we've got a chance of doing it in the rest of the NHS.
Right, can I thank you for that? The 10-year plan will be a topic that we will absolutely be returning to in our future sessions, and we will be hoping that you and your ministers will be able to return to the committee to answer questions, Secretary of State. And also we're really looking forward to having Jim Mackey in September to go through the ICB reforms and finances in more detail.
Like Jim.
So I think we've been pussycats. On that note, can I say thank you all for coming, and you've done a great job in a short space of time, and the committee. Order.